Hello, everyone. Welcome to KCash Global Education Forum. I'm Tamer H.Mohmoud. I'm Chief of the Retinal Department at King Khaled Eye Specialist Hospital. We'll be moderating this session. With me is Dr. Radial Scan, a retinal consultant in our division. He's responsible of all your questions. You can send the question to him, and we'll read them at the end of the lecture. Our guest tonight is Professor Tamer H.Mohmoud. Welcome, Tamer, and thank you for accepting our invitation. For the ones who don't know, Tamer is a professor of ophthalmology at Oakland University William Beaumont School of Medicine. He's a partner of the Associate Retina Consultant in Royal Oak, Michigan. He's author of more than 100 publications. He was invited speaker in hundreds of scientific meetings, member of prestigious scientific societies, and a valuable mentor and teacher in the retinal field. He will be giving a lecture entitled Macular Hole in Social Isolation, Can Flap and Transplant Survive COVID-19? Thank you, Tamer. The floor is yours.
Great. Thank you very much, Marco. And I'm going to share my screen now, if I can. Let's see. So can you all see the screen now?
Yes, we can.
Great. So let's see. So thank you very much, Marco, and I'm very excited to be with everyone today, and Ramadan Mubarak to everyone. I was excited that I had a chance to give that talk and have a good discussion about macular holes, but I hope in the future we can physically all meet soon as we used to, see each other, hug each other, and enjoy the company. And we'll have a chance to visit King Khaled's Hospital in the future. So, you are all wondering about, macular holes and specifically the title that I chose today. So I don't have any financial disclosure related to any of the material discussed today. But these are the objectives of my talk today, and we will have a good chance, I hope, to have a good discussion at the end. So the first is management of macular holes during COVID-19. And people would think, well, what is the difference? It's not going to make any difference. The surgical procedures for macular hole will be the same, irrespective of any infection. But I will tell you that this is very timely now. Why? Because when you look at the retina surgeons around the world, we are not usually now doing surgeries for macular hole. We are only doing surgeries for urgent and emergency ophthalmic and retinal procedure. So if you have a patient in your clinic with macular hole and you cannot do the procedure, the patient has a lot of questions. When can I have the procedure? What's going to happen if I wait and don't have the procedure? How long can you wait before doing surgeries for macular hole? The second thing is macular holes in social isolation. And we think about social isolation being far away from each other to prevent any infection. But I want you to think about it when you also think about macular holes. Think about the word isolation. The only way we can be successful surgically at closing macular holes and improving vision is to isolate the hole. So how can we isolate the hole? Through a gas bubble in the vitreous cavity, through a scaffold like an ILM flap, or putting tissue in it like a transplant. So we're going to discuss all that today. Now, I'm going to suggest and show you my algorithm and how I treat different types of macular holes nowadays. There are so many varieties, so many holes, so we can try to make some choices about different procedures, and then also discuss some of the complicated procedures and nuances about flaps and transplants. Now, this is the American Academy of Ophthalmology suggestion for retina surgeons about urgent and emergency surgical procedures that we can do nowadays. And you can see the list, and I would even add to those some of the cases of submacular hemorrhage in a monocular patients or doesn't respond to an injection. And you can see macular holes is not on that list. So let's now go back to the basic. We always talk about transplants and flaps and some complicated surgical procedure, but I think it is very important nowadays to actually go back and consider some of the basics and some of the understanding about macular holes that we can tell our patients in the clinic. Now, when you look at the gas classification, 50% of stage 1 can spontaneously resorb. But those are not actually macular holes. If you think about it, those are kind of vitreomacular traction. But once you have an actual hole starting at stage 2, those usually would not close. Only 11% of stage 2 would close spontaneously. Now, when we go back to the stage 1, or what nowadays we call it vitreomacular traction, most of those patients you would just observe in the clinic, and more than 2/3 of those patients would spontaneously resolve or not progress. But when you look at our study, when we examined all the OCT from patients in the ocriplasmin study, now we know that those that present with vitreomacular traction, but additionally subretinal fluid at baseline, are the ones that would rarely improve, and you have to consider a surgical procedure. So for those patients, you need to bring them back to clinic sooner, within few weeks, and plan a procedure. Now, what do we know about the timing of pars plana vitrectomy, and what's the effect of delaying surgical procedure for those patients? Closure rate for surgical repair within 1 year of symptom onset is 90%. However, when you wait longer, less than 50% would close spontaneously. And also, when you look at the timing, 74% of untreated stage 2 macular holes will progress to stage 3 and 4 macular holes by 12 months. The larger the size of the hole, the higher the stage, the less the chances that hole can close, less chances of improving vision. And therefore, delaying by few months may not be a great idea, but by few weeks may not make a big difference at this stage. Now, it is also very important, therefore, to make a differentiation between a vitreomacular traction and an actually full thickness macular hole. You may think, oh, I can just do an OCT and I will know the difference. Why is it important? Because if it's only vitreomacular traction without subretinal fluid, you may ask them to come back in few months. You would not be concerned of a significant drop of vision or progression of the disease. But if it is a stage 2, like we said, in few months, it can progress to stage 3 and 4. Now, I want you to look at those OCTs. Try to find the difference between the superior picture and the upper picture and the lower picture. When you look at the radial scans in the upper picture as it goes around, you definitely can see a small stage 2 macular holes, which you do not see in the lower picture with the raster scan. So we did a study a few years back, and we compared the radial scans to a raster scan, and we found that the raster scan through the fovea, because it's only one scan with wide spacing, can miss 20% of the small stage 2 macular holes. And this is because you can see at that graph, the spacing is so small with the radial scans, and also every single one of those scans is going through the fovea. So I advise you, if you see any of those patients in clinic, to consider doing a radial scan so it can help you make a decision about when to see them back and about the procedure. Also, I want to stop for a few seconds on this slide. Let's go back to the late 80s, when Kelly and Wendell first started doing macular holes, and everyone was looking at it, it's like, what are they doing? Are they crazy by doing vitrectomy for macular holes? Look at the results that they initially published in '91. Closure rate only 58%. And nowadays, we have what? More than 90, more than 95% closure for small holes. But also, we're going to go back to this slide and put it in perspective when we think about where we reach nowadays with the flaps and the transplants. Our patients also always ask in clinic, what's going to happen to my fellow eye? Am I going to lose it from a macular hole? And I usually tell them, if there is no PVD in the fellow eye, usually you have a 10–15% chance of developing a macular hole. However, with a PVD, it drops to less 1%. Now, instead of showing you first the videos and all those complicated cases, I would like to start by my algorithm for treating macular holes. So nowadays, this is what I follow. Every surgeon is a little bit different. There might be evolution of some of those procedures, I'm sure, in the next few months. But if I see a patient with a primary macular hole, never had surgery before, small stage 2, less than 300 microns, no epiretinal membrane, I only do pars plana vitrectomy. I don't even touch the ILM. And I think this is very important because we're understanding more every day about the value of the Macular cells and the ILM. And I always think about less is more in surgical procedures. If those patients are a little bit chronic or larger than 300, I always peel ILM in those cases. If we get to larger than 400 with a non-myopic patients, I go for an inverted ILM flap. However, if they are the same size myopic, moderate myopia, or high myopia, then I go for an ILM retracting door flap, and I'm going to explain how that is. Anything larger than 700, we may go for a primary transplant. Anything refractory, my threshold is very low to go for a transplant, and I'm going to explain why and my experience through that. So if you see a very small hole and patients notice a change in vision very recently, partial planar vitrectomy would do it. And you see a very nice contour of the macula without even peeling the ILM. But we are also here today to mainly discuss those unusual primary holes. What can we do nowadays to improve our outcomes? I don't think it is fair to say that, oh, we just go ahead and peel ILM on every case and our results would be fine. No, it is not okay. Because now we have data and evidence-based medicine from studies like Stano-Rezo's study with over 600 patients. When they compare the primary ILM flap to the ILM peel, and when you look at the large size of the hole here, 95% closed with the flap versus 78%. And if you don't do many of those cases, you would think, oh, I don't think I have any difference. I can just peel ILM on every one of those cases. And you may have 8 out of 10 closed, while in his cases is more than 9 out of 10 closed. You may not detect that difference if you are not doing many of those cases, but with a large number of cases, you can detect the difference, and we should consider an ILM flap initially for any of those cases. Because when it gets complicated and it doesn't close, now you have a bigger problem. The case is more chronic, and you have to be creative about other procedures to consider at this stage. This gets even more enhanced in cases of high myopia, where you can see the significant difference in closure with a higher rate of success with the flaps. Similarly, with Grazia Pertilli study in high myopic patient, and you can see that huge difference between closure with the flaps, unlike just the ILM peel. Now, we can all do inverted ILM flaps. However, there are some tricks and tips for the flap, creating, positioning the flap. You can try to use PFO or viscoelastic to keep it in place. There can be dislocation with fluid air exchange. How can we do it? Fractionation of the flap. Dissociation of the nerve fiber layer when you peel on the nasal side. And one of the problems that I don't like when you have a high myopic patient is you don't completely remove the traction around the hole. And this is why we developed the ILM retracting door. And this is the best way that I like to do those cases. I like to do the whole thing with the finesse loop because it's more accurate and more controlled than the forceps. So I start nasally close to the disc, demarcate that area of the ILM above and below the fovea, and use the finesse loop for the whole procedure, move it completely over the hole temporarily as much as I can, and then I move it back to the hole, and it stays in place. And so how does holes close in this way? So this is very nicely closed early on, vision is already 20/40. You have to look at our publication. This is a schematic that can explain it. People would ask, why would I, in high myopic patients or those patients, moderate myopia or others, why would I have maybe I can have the hinge of the flap superior or inferior or nasally? No, you cannot. And it's not gonna be as successful as having the base of the flap, the hinge of the flap on the temporal side. Why? There is significant tangential traction in myopia. When you start on the nasal side and move that flap all the way to the temporal side and let it go, that flap, you can see the red arrow, is gonna move to the temporal side and cover more of the hole. More importantly, when you look at the Terasaki study in AJO, you can see the OCT angiography. The white is the hole prior to the procedure. Red is actually the hole after the procedure. And when you overlap both, you can see that the red moves nasally to the white. And therefore, the retina itself under the gas bubble, where after the procedure, moved from the temporal side to the nasal side. So when you look at that graph, if the graft now or the flap moves temporally and the retina moves nasally, then you have a very high chance of closing those holes. And this is why we maintain that orientation. Now, there are big advantages of the retracting door: complete relief of the traction around the macular hole. No need much to manipulate the flap. The higher the myopia, the more the retraction of the flap to cover those complicated holes with the staphyloma. maybe there is an advantage of on the long run of keeping the ILM with the same orientation and not inverted. And there is a value of keeping the ILM in place and not completely peeling the ILM. Now I'm going to move a little bit to the more complicated holes, and we are very excited nowadays, the last few years, to have so many options for recurrent macular holes. But I like to simplify things and classify it into either a scaffold or a tissue procedure. So by isolating the hole again, we can create a scaffold. The scaffold can be an ILM or a lens capsular flap, amniotic membrane, or in cases, for example, or high myopia or very large holes, it is important to consider a tissue like the retina or the choroid or both to bridge the gap and let those holes heal. And we're going to discuss more outcomes of those procedures. But I want to go back and let you know about some of the frustrations that I had with some of those large macular holes or recurrent holes and why I came up with that decision and algorithm that I use nowadays. So this is a 64-year-old female that had a full thickness macular hole, chronic, non-myopic, phakic, and you see how large that hole is, minimum linear diameter more than 1100. So it's interesting that even in such large and chronic hole, the hyaloid was still attached, and I detached the hyaloid. And I usually use ICG to stain the ILM, and this is what I did so I can get an idea about the ILM and the membranes in those cases. And you can see the negative staining in the center. And I thought that the membrane is not very thick, and if I peel it, I'm gonna lose the ILM and not be able to create a flap. So I used the membrane with the ILM, and very slowly I was able, with a controlled fluidics, to keep it in place and completely cover the hole. And you see the OCT, it's very nicely closed. There is a very small eccentric area. However, the vision stayed the same. The patient still has a scotoma. And you can see post-op picture, the extensive RPE changes because that hole was very chronic. This is another one, a male, 58, high myope, had 2 prior procedures. First, a trial of an ILM flap, inverted, and another one was a macular buckle. However, it stayed open. I was planning to do a transplant, but I said, you know, let's go in and check what type of staining we have during the procedure. And when I stained with the ICG, I found that, oh, I still have a lot of ILM left. And therefore, I decided that I'm not going to do a transplant. Let me be a little bit more conservative, work with the ILM initially. And I was successful getting from the temporal side an inverted ILM and kept it in place. And I put silicone oil in the eye because he had to fly back home. And the hole is very nicely closed, covered with the flap, covered with the ILM flap. However, it's still open. Even at 3 months, you can see that the hole is still open. It took 11 months before that glial tissue under the silicone oil completely plugged that hole. There is no retinal tissue. This is actually more of a glial tissue. The vision is about the same. The scotoma is about the same. This is another one that had 2 ILM peels before with a very large hole. You look at the minimum linear diameter of the hole. And I thought I can be more creative. And I always make a decision just when I go in to see how much ILM is left. You can see the significantly blonde fundus. Hence, we really need the staining to understand how much was peeled before. And after I did the staining and I removed the ICG, I found that, yes, that patient had a very large ILM peel all the way to the arcade. But I put PFO in the eye and I thought, because I may lose the free ILM flap, maybe I can do something new. So I considered what we call a pedicle flap. The advantage of the pedicle flap, you can keep the ILM as one sheet and it is connected to the peripheral ILM, so it doesn't go flying in the eye and everything is very controlled under the PFO. And I was able under the PFO to keep the flap as one flap, but it is connected to the peripheral ILM, so hopefully I can keep it in place. And then I did a very slow fluid air exchange and I was successful keeping it in place. I was very excited at months 1 that that hole is completely closed. However, at months 2, it opened again. And this is what happened, and this was my experience with the pedicle flap. Gradually, there is more contraction of that pedicle flap close to the origin of the flap, and most of those holes would open again, so I stopped doing those types of pedicle flap. This is another lady that had 2 prior ILM peels, was also a large macular hole. There was extensive atrophy in the periphery. So I decided that, you know, maybe I shouldn't try to do a transplant initially. And the ILM was very fragmented, and I decided not to do a pedicle flap, so I thought it can be controlled under the PFO. So I tried to get under PFO a free ILM flap to close the hole, and I was successful. See, the field is very controlled under the PFO. You don't lose that flap, and I used the finesse loop. I was successful to cover that area of the hole, and then very slow fluid air exchange, and I kept it in place, and it closed. And you can see that ILM plug at the hole, and so far, even in few months, the vision is about the same and it didn't improve. So this is my experience with some of those flaps for those very large and unusual holes. The videos look great. The holes are closed, but the vision is very limited and didn't improve the scotoma. And then I come back and say, well, you know what? I was excited about the transplant initially, and I'm going to be more aggressive with transplant in those cases. And I should have considered in that first case a primary transplant, and those other cases with recurrent holes going back to the transplant. And this is why when I go back to my algorithm that I showed you initially, this is what I like to do. When I have a refractory holes, I always consider the transplant now, or other procedures like the amniotic or all that, but I'm not going to get into a lot of details with that. I'm going to focus on my experience so far. And also, for those larger primary holes, you should really consider some of those newer procedures like the transplant. Now, I'm going to move now and give you an idea about the second part of the talk about our experience so far with the autologous retinal transplant. And I always like to start about my initial case few years back when we developed the procedure. She was a high myopic lady that had multiple detachments before. And the whole idea of going in was to actually close the hole to prevent recurrent detachment. Everything pulls into the staphyloma, including the ICG, and it is impossible to get a free ILM flap for some of those cases. And the retina was already very thin. So what I thought about instantly during the procedure, if the retina is very thin, why don't we get a piece of neurosensory retina and plug the hole? Because the vision is not going to improve. Our objective here is actually just to close the hole so we can prevent recurrent detachment. And this is what I did that day. And we were excited under oil with a direct PFO silicone oil exchange that the hole was closed. But what was very exciting is that that peripheral retina gradually thickened as the vision improved, developed outer layers, and gradually with the vision improvement, there was colocalization with microperimetry over the center of the graft. So we thought something is new here, and we have to explore that more and understand how this works so we can help those patients. We published this a few years back. And then since then, many groups around the world started exploring the idea of the autologous retinal transplant. And this is one of the earlier group in Taiwan publishing their experience. And they published recently another study with better improvement and better anatomical outcomes. So therefore, with some of the surgeons that adopted initially the technique, we thought that we can look at our data without excluding anyone so we can report our possible complication, our initial experience with the transplant and how to do it. We had, and this was published in Ophthalmology last year, we had 41 eyes of 41 patients. All of them were refractory and had prior procedure, either an ILM flap or a peel, with a mean of 1.5 procedure, and followed for about 11 months. Significantly large holes, I would call them giant holes. You can see the minimum linear diameter as a mean. Many of them were high myopic patients. 88% of those holes closed with the transplant with a negative Waskey-Allen sign. When you look at the ellipsoid zone and the external limiting membrane, there was significant decrease of those with healing of those closed holes. But more excitingly, in that initial experience, 37% of those very chronic large holes had more than 3 lines improvement in vision. 41% were stable. And those stable patients were very happy. And I'm going to go back to those complications as you would expect with any vitreoretinal procedure, nothing significant. But this got us very excited to try something new and also expand it to all those surgeons that have globally initially done the experience to understand from their experience. And we expanded the study through different societies and told them to report their cases, report all their complications, their initial experience, and ask patients how they feel about the procedure. And we were very excited to get patients from almost all continents to report the procedures. So let's go through some of the data today. It's exciting that it's not only refractory holes, some of them are primary holes. 33 surgeons were involved from around the world. 129 patients that had the transplant for 2 years. We included everyone, didn't exclude any complication. And when you look at the ethnic background, people of, patients of every background, which makes the study much stronger so we can understand how those people or how those eyes heal. So it's exciting to have 27% were primary holes. And this is not your usual holes. You have to understand why every one of those surgeons decided to go for a primary transplant. Those are experienced surgeons, and they were very frustrated with their outcomes, just doing an ILM peel for every one of those patients. So those are not regular holes. Those are very large or unusual or myopic or traumatic holes. 58% were refractory macular holes with 1.6 prior mean of prior procedures, and 15% with the complicated macular hole retinal detachments. So some of them were longer axial lengths, but the mean was 24.6. Very large holes, as I explained. 90% was only neurosensory retina and 10% combined with a choroid. And when you look at the location where the graft was from, mostly superiorly, but few also were from the infranasal area. 84% were posterior to the equator and 16% anterior to that. And this is the average size of the graft, indicating how large those holes are. 81% were in the pre-retinal space and 19% decided to put it in the subretinal space. 61% ended with silicone oil, either a direct exchange with PFO or in between going through fluid air exchange. 20% left the PFO in the eye, and 19% had a gas tamponade. The success to close the hole was about 88.4%, which is very similar to the initial surgeon study in those very complicated cases. What was very exciting is describing the morphology by OCT and how those holes heal. When you look initially at the retina in that place, it looks like any piece of tissue without any layering. But look what happens at 1 month. You start seeing the ellipsoid and the external limiting membrane, and by 3 months, it goes all the way through the transplant, and you can see very nicely the thickening and the layering. One of the findings that I'm very excited about, and Stavros Moisidis, our fellow from last year, and Nicole Colissis, and she's a resident now at USC, helped coordinating all that study, and they did a fantastic work. Look at the graft within the macular hole. Look at the edges of the transplant. Initially, between the graft and the host, you see that vertical line. And gradually, over a few weeks, look at the layering. The retina becomes a little bit thicker, and you see every layer aligns, plexiform to plexiform, nuclear layer to nuclear layer. And those are the patients that improve more with the loss of the scotoma, as if the retina understands that this is a piece of tissue of its own retina, and I'm going to connect to those cells. So the average took about 4 months for the reconstitution of the external limiting membrane and the ellipsoid zone, and about 4 to 5 weeks for the linking of the neurosensory layer. Overall, as a group, the vision improved significantly. But what's very exciting is that also 43% gained more than 3 lines of vision in that global initial experience. 29% gained more than 5 lines. And this is a group that I was very excited about. 6 cases had final vision 20/25 or better. This is their initial mean vision and last vision. And 2 patients got to 20/20. And they got to 20/20 in those unusual holes, not at 3 months or 4 months, by 16 months, indicating that it is a totally different way of healing for those types of macular holes, and that possibly that peripheral retina can achieve macular function. These are the complications that we had initially in that global study, and you understand the frustration of some of those surgeons initially with a graft dislocation, but the numbers are so low, and nowadays we can do much better. So it is important also to know, what did we learn from that initial surgeon study and the global study? Integration of the transplant takes 1 week to 1 month, and this can help us make a decision how to improve and change things. Look at that OCT. The upper picture shows initially post-op day 1, and then the lower one at 1 week, and the transplant is completely secure in place with differentiation of the layering by 1 month and linking of the neurosensory layers. And this is why nowadays it is safe to leave the PFO in the eye for 1 or 2 weeks and then take it out, because we know that the transplant is secure in place. Another huge advantage is that the diffusion of oxygen through PFO is 17 times more than silicone oil. We need that oxygenation for the transplant initially for a better function and for the transplant to survive. And this is how I like to do it nowadays, uni-manually. It's very easy to do it for any retina surgeon. You add PFO, get a size 25% about larger than the size of the hole, and then add the diathermy about 4 spots away from the area of the transplant so you get an idea. Start cutting with the vertical scissors around the area of the transplant, like I said, and the laser should not be encroaching on the edges of the transplant. You can go on the surface of the retina. You can move it with the forceps, or what I really like is using a finesse loop. If you don't have it, you can use a Tano, and very slight motion, step by step at the edge of the transplant till you get to the hole. I like one edge of the transplant to be against the edge of the hole and then overlapping from the other edge. So if we do it this way, there is no excuse. 100% closure of the macular hole can be achieved, which would reflect at a much better functional improvement. And you still have a second chance because you have the PFO in the eye and you are going back at 2 weeks. This is a patient that had 2 prior inverted ILM flaps and he couldn't close. And then I did a transplant and he didn't maintain the positioning. I always tell them anything except face down, but sometimes they can, their head can move down the chair when they are sitting and that transplant can slightly move. But it gives you a second chance when you have the PFO in the eye. So when I went back at 2 weeks, before I removed the PFO, I worked under PFO, and with the finesse loop, I slightly moved that transplant in place. I know where the opening is, and I was able to move it in place, do fluid air exchange and SF6 bubble, and it's very nicely closed. A short bubble face down for a few days, then even if it's not 100% closed initially, you still have your second chance. Now, we are also wondering about the perfusion of the transplant, and this is a very nice paper that came recently in JAMA Ophthalmology by Tabande, and you can look at how large that hole is, and at 3 and 6 months, you can see very nicely the perfusion on fluorescein angiography of the transplant, also by OCT angiography, partial perfusion of that area of the transplant at the different plexus layers. This is another one, also a large hole, and you can see nicely the perfusion by a fluorescein angiography and also an OCT angiography. Now, I'm going to step back and go back to that group that we discussed initially, the stable group. And what do I mean by those patients are very happy? This is one of the first patients that I did when I moved 2 years back to Michigan from Duke. And she had 2 prior flaps within a span of 5 years. And I go in at 3 months and she said, I have never seen as good as I see now for the last 5 years. And I say, I don't understand. I look at so many visits and you had 2200, 2400 vision. I don't see a big improvement. So she didn't show an improvement on Snellen or ETDRS, but she's very happy. And I said, explain to me. She said that at different distances, I had that big black spot in the center of my vision. And after the procedure, gradually, it became gray and now it's completely gone. And this is why I'm very happy, because I used to close that eye to be able to see from the good eye. Now I don't see it and I have both eyes open. I can do very well the tasks at different distances. So if we look scientifically, what the explanation of this is, she had a positive scotoma that changed to a negative scotoma. That's why she is functioning binocularly much better. When we think about our optic nerve, it produces a negative scotoma. However, when you have a large macular disease, you have a positive scotoma. So the explanation is one of the hypotheses. When you have the transplant and there is linking of the neurosensory layers at the level of the ganglion cell layer also, there is some of the connections and synapses. And this increases the receptive field, changing the positive into a negative scotoma. That's why those patients are very happy. Now let's look at some of the tips and the tricks of the procedure. It is very difficult to do the very high myopic patients. whether primary or recurrent cases, you wouldn't even know where the hole is during the procedure because of the significant atrophy. And I advise every one of you to overlap the color pictures with the OCT prior to the procedure to know where the hole is in relation to the atrophy, so that when you move the transplant during the procedure, or if you are successful at doing any type of flap, you know how to position the transplant or the flap. Also, you definitely need a long forceps with you in the OR, so you can follow the curvature of the staphyloma and be able to reach all the way to the macular hole. And one of the tricks is do not keep holding the forceps within the PFO. It's going to wrap around the forceps, the transplant, but follow the curvature of the staphyloma all the way down. Alport syndrome is one of the very complicated cases where the genetic defect is in collagen type 4. This is a patient that had an ILM flap or peel before. You cannot work on the ILM. It's very fragmented because of the deficiency of the collagen type 4. So in those cases, you have to go for a primary transplant. And in some of those patients, the genetic defect also includes retinoschisis. And this is why sometimes it's very difficult to cut that retina. And as I cut that retina, you see all that gooey material that is going out of that retina. And this is why you have to be persistent, go very slow under PFO. You also have to enlarge it more than 50% of the size of the hole and completely cover the hole. Why? Because if you don't and you have an eccentric hole, it's going to continue to enlarge and you will end up with a giant hole. So you completely have to cover the edges, and you can see it early post-op under PFO. By 5 months, look at the color picture. You don't even see the edge of the transplant, and you can see the OCT, and that patient improved from 2400 to 2060, and he was 2400 for a few years. When you have significant atrophy at the base, like geographic atrophy or multiple procedures, for example, that patient here, he was hand motion, then you should consider combining it with choroid and retina. And this is one of our publications looking at the combined RPE, choroid, and retina. And that patient in few months improved to count fingers at 6 feet. But at least this is something to consider in those patients, the combined choroid and retinal transplant. So there are so many hypotheses about the autologous retinal transplant. I'm not going to go through those details, but there is so much basic science about every one of those hypotheses that has been published for the last 15 to 20 years. And I would like to end with that algorithm that I started my talk with, so that you can think about it, consider it. Every surgeon will have a different algorithm, but we all have to work as a team to come up with the best option for each one of those patients. And this is why my threshold is very low nowadays, because of all those numbers and studies, to go initially for a primary transplant in those very large unusual holes or refractory holes. Thank you, and happy to start the discussion.
Thank you, Tamer. It was a very nice presentation, very exhaustive. We're going to start now collecting the questions. I have some questions for you. Can you hear me?
Of course, please.
Okay, sorry. I have some questions for you. I see in your algorithm, you don't do free flaps, right? Even if it is a hole which is already been operated, there is no really a possibility to do an inch. If you exclude free flap a priori, or it's something that you found out it doesn't work and you go directly to autologous?
Yeah.
What is your, yeah.
So a great question. And this is why I wanted to show all those videos where I actually did a pedicle flap or a free flap initially, because I thought, why would I be so aggressive and go for a transplant? Why don't I try one of those flaps initially? So my personal experience, I was very successful at closing those unusually large or recurrent holes with the free or pedicle flap. However, either they opened again or they look closed, but the vision was about the same and the patients were not happy with the same type of scotoma. So once I went through that phase, I said, no, I'm going to go back. And because of the data that we have now, any of those large holes, more than 700 or recurrent holes, I just go for a transplant nowadays.
Another question about this, because I see you in US, you use ICG. Are you not afraid to put the flap with ICG inside? I mean, could that be a reason why the flap with the free flap would have not improvement in vision, or you exclude that?
So I think it's very difficult for us to decide whether ICG does anything because we all have fantastic outcomes from just peeling ILM and using ICG. So what I usually do, if you had seen some of my videos when I moved to doing some of those flaps,
you put perfluorocarbon.
Exactly. So I put PFO and I move the eye so that I avoid that the flap would go. And anytime that I did one of those flaps, I never shove or push the flap in the hole. I just cover the whole area.
Okay. Okay. Another question. Can you predict, because I mean, it looks like there is a very large variability in the result. Can you predict which one are the holes which would do better with the autologous transplant from the others? Is there a way to recognize them from the OCT or your experience?
Well, great question. And this is why we try to do a significant analysis in the global study with the big numbers to understand why some did much better than others. So there are so many confounding variables. And although we have a large number, 129 eyes in the study, we cannot come up with those conclusions. Why? So one of the variables, is there a better location? If I have two patients with the same chronicity, same size of the hole, and one gets a transplant from superior temporal area, another one gets it from the inferior nasal area. One has a significant improvement in vision, the other doesn't. And they were both successful anatomically. Why would someone be better? Is that location better? Although we have a large number of patients in that study, we cannot come up with that conclusion because there are so many locations where the flap was taken from the study. But I think this can partially explain why some of those locations can be better. Let me put it to you in a different way. Let's say if we go back to the 60s and 70s, there were some published studies that all of us are born with a peripheral zone of dormant cones. We don't know exactly where it is. So let's say all of us are born with a location in our peripheral retina that have cells that can act as stem cells for photoreceptors. And we don't know that location. In the future, once we have a test, for example, wide field adaptive optics, or a better testing, and we can image those babies when they are born. And let's say, you, Marco, or me, when we're born, they take an image of the right eye and they say, oh, those cells are at 11 o'clock in your right eye. Those cells are at 5 o'clock in your left eye. If anything happens to your macula in the future, this is where you can get the cells from. We don't have those capability yet, and it may look like, or seem like science fiction. But if you think about it, this is some of the explanation. And when you look at the slide that I had about the different hypotheses, there are some of the hypotheses about peripheral Mueller cells in cases of detachment or insults to the eye that can differentiate into stem cells for photoreceptors. And maybe this is why when now I treat primary retinal detachment with vitrectomy, I don't go crazy and do 360 laser. I only do laser to the location of the break. And I hope it's safe because I don't know what I'm killing by going 360 and doing extensive laser.
That's a great point. We should try to spare the retina nowadays as much as we can. Is there a difference between subretinal and pre-retinal positioning?
I don't know.
In outcome,
question.
The one you saw.
Yeah, from the global study, we did not see any difference between the subgroups of pre-retinal or subretinal. If you think about any surgical procedure, myself, I try to put it in the pre-retinal space with one edge against the edge of the hole and the other edge slightly overlapping. I try to avoid myself any dissection in the subretinal space because when you look at the microperimetry and other tests that we have done, we're also getting really good signal at the edges of the hole. So if you're getting good signal at the edges of the hole, if you try to be very aggressive at the edge of the hole, trying to push it in the subretinal space, you might be destroying some of those cells that can help with the visual function.
I understand. We did some cases very early on when you started reporting the technique at KCash. To be honest, I was not amazed about the function result. I mean, they all close. The functional result was not great, but you pointed out something very important, which we didn't do, and it is looking at the patient very late on. I mean, there is a follow-up of patient improving after almost 2 years, you reported. So maybe that's the trick. We should re-examine our patients, maybe.
And like I said, you know, we have, and this is the global initial experience. Now we have advanced so much. The technique is much easier. We know which cases we can do it. Surgeons are more aggressive doing it initially in patients that are tough to close in their hands before they become very chronic. I mean, if you have a very chronic macular hole, the RPE is already lost. Very thin choroid in myopic patients. What do you expect only from putting retina? So this is why we should now start thinking more. If it's very chronic, we should consider something with choroid. If it's not, then you try to do it early on before it becomes very chronic.
The last question, because I see in our guest list is also Carlos Mateo, which is an expert also in this field. Do you think there is still a role of macular buckling in this era of the tissue transplantation and ILM transplantation?
So I'm going to tell you my impression, my opinion, but I would love to hear what Carlos has to say, because he's one of the experts in those macular buckles and he had really good results. I have not done those, and it is a more complicated procedure, maybe not in Carlos' hands because he's very experienced in that procedure. But when you look at the macular buckles, many of those holes are also the very high myopic holes. Yes, you can support that area of the break or the hole with the buckle, but many of those patients will end up with a flat open hole. So you didn't actually close the hole. You still have to combine it with a procedure for that tissue. When you push that buckle from the back, you are pushing the retina aside, and maybe the hole would be larger than the size of the hole, and you might be also compromising the choriocapillaris and so on. So since now we can close every single hole, either with a scaffold or a tissue, I don't consider some of those procedures, but let's see what Carlos has to say.
Dr. Adel, if you are there, could you see if Dr. Matteo is still online? We can open his mic.
Yes, I can see him. Carlos, you need to unmute.
He is unmuted from my side.
Dr.
Carlos?
Can you hear me now?
Hey, Carlos.
Yes, we can hear you.
Hey, how are you? Congratulations, Marco. Congratulations.
Thank you. Thank you.
Great meeting, great presentation. And let me ask you, I am the other side, okay? Tamer, I started with RT transplantation some years ago, and we mentioned this. Let me ask you about, I saw, you haven't shown any case of these cases with, after 2 years, that they show edema around the hole and retracting the transplant and reopening the hole. Have you seen any case? Because I've seen some cases like this. And the second question is about the retracting door that you use. You do magnificent work, and it takes for me more time to trying to with a flexible loop to put this ILM. You're pressing the retina many times to do the retracting door, and I don't know if you don't see the dumbbells because you have the ILM over the retina, doesn't mean that you don't hurt the Miller cells because you don't see them, but are you trying to see if you have a reducing in the retinal thickness or other sign to know if the Miller cells have been traumatized? And about the buckles, I reduce the indication of the macular buckles, and I only do macular buckles now for retinal detachment and macular holes when you have a big hole, big macular staphyloma. But anyway, thank you very much for your presentation. It's been very clarified. You changed your flap. You in the very beginning was very peripheral. Now it's more posterior where you grab the flap. Why did you change this? Many questions. I'm sorry.
Yeah. So I wrote all the questions. So,
okay.
So thank you very much, Carlos. And this is what I said to Marco. The best part is the discussion. So let me go one by one. So the first one, you were talking about the long-term outcome and if I see any retraction of the transplant and thinning. So yes, great question. And so one of two things. Number one, we have seen in the global study and the initial surgeon study, after 6 months and 1 year, some of the transplants, about maybe 15–20%, will get inner retinal edema in the inner retina. And that inner retinal edema, we didn't treat it with any, like macular edema, with any drops, and gradually it improved. It didn't affect the functional outcome. But more importantly, I'm going to talk about the retraction. Yes, we looked at it, and specifically in my cases. So if you remember, I talked about the radial scans in the fovea. When we have, even after a transplant or any treatment of macular holes, if we only have raster scan, we can see the transplant or the flap in the fovea. But if you do radial scan for any of those patients, you will see all the way around the hole. So let's say we have a transplant and we put it in place, but the transplant is in the fovea, but outside the fovea, away from the fovea, because it's very large transplant, it is still open. So we would call this an eccentric macular hole. Patients that have an eccentric macular holes with complicated cases, especially the one that had retinal detachment with PVR, would gradually retract with time, partly because probably the PVR process and so on. So those are the patients that over time will continue to retract, the eccentric hole will gradually open more, and the outcomes are not great in those patients. And therefore, it is very important to do a radial scan around the fovea. Make sure before you go and remove the PF hole that all the edges are completely covered. If you do that step initially, and this will allow the linking of the neurosensory layer around all the edges of the flap, avoiding the eccentric holes, allowing the reduction of the scotoma because of the linking of the neurosensory layers. So it all now makes sense and going in correlation. So this is what I wasn't looking at before, but we know that those are the patients that did much better. For the second question about the ILM door, I know what you're talking about the mechanical effect during the procedure. And if you look at the video, I am not really pushing down. It's very thin. And the only way to get the ILM is very slowly get it off the hole. I really like in those myopic patients when I completely relieve the traction around the hole. It's easy to put it in place, even if it's slightly retracting. When you do a very slow fluid air exchange at the disc and slightly tilt the eye, the flap will come in place and cover the hole. And all those closed in my hands. I don't do it in non-myopic patient, but for those cases, definitely all of them are closed. The OCT morphology looks really nice and much better than ILM peels. Now, your question about the long-term outcome, whether it makes any difference in the function of Mueller cells, I cannot answer that question because we haven't specifically tested functionally. But now the more I understand about posterior Mueller cells and peripheral Mueller cells, I feel there is a value on the long run to keeping those in place. One of the cases that I had before, a very large hole that opened even with a retracting door, remember that that flap is completely covering the hole. So when I go back for a second procedure, I still have ILM now at the edge of the hole. I can go for an inverted flap, so I still have a second chance. When the last question, you talked about the buccal already. The second question about the flap location. So yes, initially I was trying to go peripherally to get the transplant and cover the hole because I try to avoid making a retinotomy close to the posterior pole, so I can preserve the posterior pole as much as I can. Now from the global study, we didn't find any difference about the location where we get it from, or it's not like we didn't find a difference, we don't have enough power in the study to compare those different locations because there are so many compounding variables. And therefore, why would I go for a very peripheral retina that is very thin, very difficult to cut and move to the macular hole? I am right-handed, it is much easier for me to go above the arcade where I can easily move it and cover that area of the hole. Also in the global study and other studies, we haven't seen any new scotoma related to that area where we got the transplant from in close to the posterior pole. The only situations where I really get it from the periphery, if someone has a retinal detachment with PVR, they already have a detachment. When I do a retinectomy, I get it from the peripheral area of the retinectomy. And this is based also on the hypothesis that peripheral Mueller cells, when they are primed, they can differentiate into stem cells for photoreceptors, but we never moved them to the macula. But that's what's exciting about that hypothesis.
I think we have Dr. Faisal Fayyad who raised his hand for a question. Dr. Faisal?
Hello, everyone. You hear me?
Yeah, we hear you very well.
Yes.
I wish to see you in real life, not just virtually.
Inshallah.
Unfortunately, we missed this April Amman Retina meeting to talk COVID-19, but we'll make it soon, inshallah.
Inshallah.
Definitely.
Congratulations, Marco. Congratulations, Tamer. It's excellent presentation. My questions, first, my comment, as Marco mentioned, I succeed in closing the hole, but often the vision is very poor or the same. But I heard your answer to Marco, and that satisfies me. The question is, once you take, the graft, the retinal graft by finesse under heavy liquids, and you move it with the finesse to the macula, do you hurt the retina? Did it ever happen that you hurt the retina?
Great question, Faisal. And we discussed the different aspects of the procedure at different meetings, but there are two ways you can get the transplant. One way is to, under PFO, use a vertical scissor and cut it, and then move it very slightly on the surface of the retina. Of course, it looks like we are not pushing on the retina, but it looks more macroscopic. On a microscopic basis, definitely we might be hurting some of those cells. But also it is a problem when you lift it up that it can shrink the transplant, you may lose the orientation of the flap. And this is why I feel that the advantage is more to move it with a finesse loop very slightly at the edge on the surface of the retina, but I can never exclude any microscopic trauma to the flap. Another way that Steve Charles and Kazuaki Kadonosono were doing it initially is, instead of doing what I am doing, they go with a subretinal cannula, they inject and induce a detachment in the periphery, then cut it, and then take that flap and take it to the area of the hole bimanually. Now, the disadvantage of that is, number one, you add bimanual techniques, which you may not need. The second thing, although you did not move the flap over the surface of the retina, you may have done more damage by injecting with the subretinal cannula to detach that retina where you're getting the graft from. So these are the two options to get it from. In my hands, I use the uni-manual, and I think it causes less trauma. And I think this is what Kazuaki and Steve are using at this point. However, what I really like is that there are amazing retina surgeons around the world, and we are improving things every day, and someone may come up with a better idea with less trauma. One of the videos that I enjoyed and I have seen from India, one of the surgeons has developed a trephine that you can use in the eye, so you can go in and cut your flap and move it to the retina. Well, to put it or push it out of the trephine, there is also some microscopic damage. So I think eventually it's about the same, but someone may come up with an idea to completely avoid any even microscopic trauma.
Excellent. I just was wondering if you ever lost your graft during surgery, and if you did you make another one?
Great question. Can I share my slides? I can show you a video.
Yes, absolutely.
Can we go back to my slides? So let's see. I don't know if you will be able to, let me open, and you tell me if you can see this one.
If you share the screen, should it be okay?
Can you see it?
You need to press on share screen, and we can.
Okay, hold on. I'm gonna do one thing here. I'm gonna open a new one so you can see that video. And because I think it's easier for us to just see the video, would be much easier this way. I'm opening it now. Now I'm gonna try to share the screen. Can you see it now?
Yes.
Great. So now I'm gonna play the video here. Can you see the video?
Yes, clear.
Great. So I'm gonna stop here. Now do you see my pointer on the screen?
Yes, yes, it's very clear.
So this lady had a prior ILM procedure before and the hole stays open. Then I went in and I got a graft and I moved it to the fovea. And in my hands, 100% of those stay in the fovea. And I tell them any position except lying, except face down. So she comes back and I look and the hole is open. And I'm like, what happened? I have not seen that before. And she said, no, I listened to what you told me to do. And I look at her husband and he said, I think she was trying, but she couldn't do it. I said, what do you mean she couldn't do it? He said, she's always sitting in her chair, watching TV, and she goes to sleep and her hair drops down. So most of the time she was actually face down. So when I went back, I'm going to show you the video now, and I couldn't. I was trying to look, and I didn't even see the transplant at the edges of the hole. There were some different pieces of tissue in the eye, but I couldn't use it. So I decided to go back and get another transplant. So here with the depressed exam, and then I went back, I added PFO again, and then I'm working under PFO. I did the diathermy, and this is the inferior retina now, close to the arcade, and then cut again with the scissor. And I'm going to advance it a little bit here, and then moved it to the fovea with the finesse loop. Now, I didn't want to leave again PFO in the eye and go back for 2 weeks. So I said, now, you know what? I'm going to do a very slow fluid air exchange and end up putting a gas bubble in the eye. Look at what happens. As I am even very slow under passive, the transplant moved from the fovea at the edge of the PFO. So then as soon as possible, I went back in the eye and I added PFO, and I can see the transplant. See the transplant floating? Yes. And then it became stable in place. I went with the finesse loop. I moved it to the fovea. And then I stopped here and I said, what would I do now? Now I have the transplant. Now it moved again. I cannot keep coming back and getting more and more transplant. And I cannot risk again having that transplant move under a direct PFO silicone oil exchange or fluid air exchange and silicone oil. I said, you know what? I'm going to make sure she doesn't go face down, and I have to wait and make sure that that stays in its place. I will put PFO in the eye. This is exactly what I did. I left the PFO in the eye and she did great. She's now 20/40 to 20/50. So this is just an example, just to respond to that question about did you have it move? Yes, it can move, and I have seen it move slightly. And I can go back at 2 weeks before I remove the PFO and I can adjust it in place, fluid air exchange. It's going to be great in a good position. But I have seen it only in this patient when it completely moved when she went face down. Back to you.
Okay, I think we have a couple of other questions from the audience that I would want to share. So I see a question about younger patients who have traumatic macular hole or those related to laser injury. How is your experience with autologous transplant in those patients?
Well, I have not done any of those, but in the global study, we have 2 patients. One of them improved 2 lines and one of them improved 5 lines. So again, there are 2 things we're looking at when I decide on those patients. How big the size of the hole. We have to know that 50% of the small macular holes in the pediatric group may close spontaneously. So we should not be rushing and doing any procedure because those patients also have a very adherent hyaloid, and we may get into more complications by doing any procedure. The second thing that we have to consider very seriously for the surgeons that do surgery on babies and kids, for a detachment, or especially for tractional detachment, we try to avoid creating any holes. So this is very important. So if that hole is not healing and you decide to go in for a procedure, the way I would be thinking would be, I would be as much conservative as I can. If that patient has a small hole, I would consider doing a small hole. By small hole, I would mean maybe 400, 500, up to 400, 500. I would consider doing an ILM flap, an inverted flap. If it is larger than this, now we have not, I would say, evidence, but we have some cases that have significant improvement in vision with the transplant.
Okay, another question about the global study. There was 2 patients who ended up with 20/20 vision, but one had pre-op vision of 20/40. You know what reason that he was operated in this situation?
Yeah, so the patient was operated. So then with the ILM, and when we look at all those visions also prior to the procedure, we have to understand that this is not a prospective study. This is a retrospective study. I will tell you that I had a patient in my clinic a few weeks back, had 2 prior procedures with an ILM flap, a very large, more than 900 micron minimum linear diameter. And it's been about maybe a few months. And before I see her, I go in and see her, I look at the chart, the vision is 20/25 in both eyes. So I'm like, I didn't even look at the picture and I say, oh, she's coming to see me for a macular hole, second opinion and all that. I mean, 20/25, oh, maybe it's a small lamellar hole, she doesn't need any surgery. And I go in without looking at the chart and I start talking to her. And then I look at the images and I look at the hole and it's like, there is no way she can be seeing 20/25. And then I send her back so that they can test her vision with a pinhole, and she is actually 2400. But what is, and because I have this in my mind, I had to test it this way. And then I said, oh, now it makes sense. So we have to understand the fallacies and the problem of some of those retrospective studies. If I have a very large hole, I would never believe that that hole is 20/40, but I have to leave it this way in the global study because this is what's documented on the chart. I don't know better. If they put 20/40, I have to put it 20/40.
Another technical question. Do you think that there's a difference between the 12 cuts and 24 cuts radial scans in terms of macular hole detection?
A great question. And if you look at the details of our paper in the American Journal, we actually looked at 6-line and 24-line. And the more lines you have, the more you would be able to detect those small holes. And the 24 was much better than the 6. So my routine now is just to do the 24-line scans. If you go more, definitely it can be more sensitive, but I doubt you would be able to detect more. So I think the cut would be something like a 24-line scan.
Would you be concerned about the orientation of the tissue if it's fall on the microforceps and you're unable to unfold the tissue?
Yeah, so what do you do? And this is why I wanted to show that video of the myopic hole. If instead of following the curvature of the staphyloma, you go straight, even under PFO, because there is no support of the underlying retina, the transplant will wrap around the forceps. In this situation, I go back so that I'm not pushing on any retina. I keep it in place. I go back to where I got the graft from. I go close to the retinal surface and I open slowly my forceps. Under PFO, if you slowly open the forceps, the graft will stretch back in place, and then you can go back and repeat that step and move it back and follow the curvature of the staphyloma, or go with the finesse loop or a Tano and move step by step. I think one of the mistakes that I have seen with some of the surgeons that were initially trying the procedure, they feel that they can grab it and in one step, they have to move it all the way to the hole. No, you don't need to do that. Just go step by step. Breathe, take it step by step. It's not going anywhere under the PFO.
A question from Dr. Tariq Al-Zahmi. He's one of our fellows. He's asking if you feel that there's a place for allogenic foveal transplant in the future.
You mean taking it from what, the fellow eye, for example?
Yeah, or from
yes. So great question. And when we have those presentations, we can come up with a lot of ideas, but we have to be very careful and very ethical and consider the patient and the risks that we are taking before we consider any of those procedures. Initially, when we were doing the transplant or ILM flaps, it was very reasonable to consider it. Why? Because those patients are very advanced. They don't have any other option. So everybody's trying something new to try to improve things. And we did improve things significantly. There was a paper that was published recently about someone taking an ILM flap from the fellow eye so that they can work and close the hole in the eye that they are working on. I am very concerned about those procedures because now you are doing surgeries on both eyes at the same time. We never like to do surgeries on both eyes at the same time because if there is a risk of infection, then patients can lose both eyes. There are very few cases in the pediatric population or very high risk patient that you can work on both eyes at the same time, but that's not the standard of care and we try to avoid this. And also, if someone has a very good vision in one eye, why are you risking to go to the fellow eye to do a vitrectomy, to get the ILM to close a hole? You are not sure what the functional improvement would be. Now, this is one concern about working on both eyes for the same patient. If you are taking now a retina or an ILM from a different patient, imagine, so it's one of two things. Either that you have both patients, one in each room, and you are taking it instantly and putting it in the eye with a lot of risk moving between rooms and tissues and so on, or you are developing what we would call a retina eye bank. So if you are developing a retina eye bank, that means you are taking pieces of tissue or ILM, any patient that you go and work on for a detachment or something else, you take a piece of ILM and you isolate it and put it in an eye bank. And whenever someone needs a closure of a macular hole, you can take it from the eye bank. Well, that potentially is an option. However, I don't know how the survival of that tissue and how intact that tissue would be in an eye bank and how easy it is to get it from an eye bank to use it in the eye. The second thing, yes, we know that the vitreous cavity is immune privileged in a way. However, that tissue is from the retina. That tissue has been exposed to antigenic material and so on. So I don't know if those patients may develop an immunogenic reaction. The value of the autologous retinal transplant is that we take it from the same patients. We haven't seen any immune reaction or any immune responses, but that's something that I would be concerned about.
A question from Edberto Muniz. He says, when I do ILM transplant, I do the door hinge technique in the temporal part of the macula. So it doesn't move. Do you think that this is the ideal way to do it?
Well, this is why I describe it, because when you see the retracting door, or what we call it a rug, like a rug that moves. So, and this is why I specified in my talk that people would say, oh, I'm gonna go nasal, I'm gonna go temporal, I'm gonna go superior, I'm gonna go inferior. So let me put it this way. If you go nasal or temporal, the macula is more horizontally oval. So definitely you would consider nasal or temporal because you have more space and you can cover the area of the hole. If you go superiorly, people may think, oh, this is great because it's with gravity and it can cover the hole. But the problem is that it doesn't retract as much. And when you go horizontally, whether temporal or nasal, you would think it would retract the same. It doesn't retract the same if the base is on the nasal side because the optic nerve is blocking that motion. If it is on the temporal side, it would retract more. But more importantly, what I showed on my graph, that also the graft moves temporally, but also the retina moves nasally. Then you can really close those holes. However, you know, we gotta remember, this really works very well in myopic patients, but not patients that are not myopic because the retraction is not gonna be the same. So in my hands, if that patient is not myopic, I would do an inverted graft flap. If that patient is myopic, I would go for a retracting door. But I would like to go back to also a point that I think Carlos Mateo has raised. Patients that are very, very high myope with a staphyloma and a lot of atrophy, it is very, very difficult to control your flap. To try from very thin retina to develop a retracting door may almost seem impossible. So in those patients, for example, I use the ingenuity in 100% of my cases, and I use a biome. When you try to reach through the depths of the staphyloma, the biome sometimes is even in the way, even with the long forces, because you try to be very perpendicular and you cannot reach. So in those cases, I move the biome away, I use a flat lens, become as perpendicular as I can, always use a valved cannula so I can control the movement of fluid in the eye. I wouldn't have more outflow, so I don't lose my flap, whether a transplant or an ILM. And I go with the long forceps posteriorly, and I reach that area of the ILM, and I start creating my flap. You can start with the finesse loop, but because the retina is very thin and adherent, you may have to resort to the long forceps. And I go step by step. Even if I cannot have a retracting door, my goal is to create a flap and not completely peel the ILM, either as an envelope flap or an inverted flap or a retracting door. Whatever you can do at that step, no one can say this is exactly what I'm going to do, because there could be fractionation of the ILM, radialization of the flap. But as long as you can get any type of flap to be able to cover that hole, that's what I would try to do.
A question from Dr. Saad Wahib. He's asking about how you feel about the AMT, the amniotic membrane plugs.
So I have not done any. I have used the amniotic membrane on the surface of the eye for a big defect in the conch when a buccal is exposed, and I use it with to seal without even any sutures, because it can cheese wire. But I have seen the results of Stano. So Stano is the pioneer that worked about the amniotic membrane, and he has published some great results. So we are trying to explore more, and as a community and as surgeons, we want to know which type of procedure we can do for which type of hole. What I have suggested to Stano, and it's not easy to do it now because we cannot travel. We may be considering in the future to all of us, some of the surgeons, to stay in one place for about 2 to 3 weeks and collect a large number of cases that hasn't had any surgery during the pandemic, and randomize in a prospective way those patients so that both groups are about the same, and try to do amniotic membrane and transplants and other procedures. And we follow those patients for a few months to understand more how those patients heal. What I know at this point, and thanks to Tommaso Rossi, so he's another great surgeon in Italy. So we submitted a paper the last 2 weeks with Tommaso was the lead author on the paper that did the work with Stano and I and some groups and some of the surgeons in Italy, introducing a new classification for closure of macular holes. So the old classification show either 1, 0 or 1, either closed or a flat open hole. Now we introduced a new type 2 closure. Type 2 closure relates to the transplant and the amniotic membrane. And we have an A, B, C, and D. So this sheds a light about how those holes close, open the door to use the classification according to the anatomical improvement. We don't have a long-term follow-up. We only have 1 and 3 months. And this is also important because we can see many of the cases with amniotic, and specifically about the autologous retinal transplant, you need 16 months before you see a differentiation. And what's really exciting about this paper is that with time, as the transplant heals, you can see a morphological change in the transplant with the linking of the neurosensory layer, and a type 2 closure can change to a type 1 closure. So I think with the anatomical new classification, with more understanding and randomizing in the future, if we can, some of those patients, we can shed some light about how to come up with an algorithm for everyone to try to follow and give some more information to our patients.
I think, Adel, I see Carlos Mateo with the raised hand. Is it the new or is it old one? Can you check?
No, it's mine. It's mine. I was.
Okay.
I raised my hand. Only two comments. One is Tamer mentioned about using, the flexible loop better than the forceps, and I really agree with you, because if you grab it with the forceps, you can arrive to the macular hole. You try to release the tissue, and the tissue becomes adherent to your forceps, and it goes with your forceps. It's very difficult to put it inside the hole. And I remember we were in a car in Brussels, I think it was 1 year ago, 2 years ago, and I mentioned you, and Marco, perhaps you can answer this, and Faisal also have experience about this in high myopes. In some of them, after doing embedded flap or whatever in macular holes, some of them, they develop atrophy in the central fovea. It has been reported now, very, very, now some months ago, by the group of Ono Matsui. The appearance, of atrophy in the center of the macular hole. I want you to comment about this. Have you noticed this, or have you seen this?
You guys go ahead. Marco?
Okay. Hi, Carlos. No, to be honest, I haven't seen it in my patients yet. And to be honest with you, when there is a very large macular hole, the one you are mentioning, I don't really like to do this flap technique. I find it very difficult. So I still like to use a macular buckle, especially when there is detachment and very atrophic. But so I don't have much experience with flaps in such a high myop case.
Embedded flap, embedded flap. This is a normal myop, let's say.
Normal myop, normal myop.
8 diopters, 10 diopters, not huge staphylomas.
No. In those cases, okay, without huge staphyloma, to be honest, no. In my experience, I don't see.
Never.
I don't see. I don't say never, to be honest. But very rarely, yeah. Maybe it has to do with the technique.
I don't know. She described, I think it was 10% of central atrophy after the surgery. And I've been reviewing more than 300 cases now. And there are many cases that they develop central atrophy that, limits, the visual improvement in some of these high myopes. And I don't understand why.
And
what is the percentage of your cases that develop atrophy then?
We are studying this now, but it can be around 10%.
10%, and this is with the ILM flaps or
ILM inverted flap.
Okay, and you use in all of them you use the blue, right? You don't use any green. Brilliant blue. Okay. No, to be honest, I didn't review all the cases, so I don't have a number, but like a feeling, I don't see so much. I think I would say very rare, yes.
Mm-hmm.
But also, Carlos, if you think about those patients with very high myopia, many of those patients can have more progressive atrophy. So it is very important to try to adjust. For some that didn't have the surgery or some that did have the procedure, there are so many steps during the procedure. And specifically when we go to those very, very high myopes with a staphyloma, it's very difficult to manage the flaps and put it in place. Even whatever dye we use, sometimes we try to keep it in place. Some would put it over the area of the hole, some to try to push it within the hole. So part of it could be mechanical trauma, part of it could be the fluids that we use. There are so many variables here that it's very difficult to pinpoint and say, oh, it is because of this, or it is not also because of natural progression of atrophy in some of those patients.
I agree.
I see. Yeah. Faisal, yes, go ahead.
Yeah. Unfortunately, I lost the connection, just connected again. I agree what Tamer was saying now, but I was wondering, when do you see, Carlos, this atrophy? Soon after the surgery or after a while? This is very important.
Even years after the surgery. I have cases where you have 2 months and it's normal, and after, let's say 6 months, 1 year, 2 years, it begins to appear, or less than this, a fistula a central atrophy. Look at the paper of Kyoko Ono Matsui. This is very recent.
Yeah.
It can happen in schisis, can happen in macro holes, it can happen in retinal detachment macro holes. And I've been observing this in some of my cases from 1 year or 2 years ago.
Yeah, yeah. This is what I think. Maybe it's a progressive, I mean, degenerative changes due to myopia itself. I can't relate this just to macular hole surgery.
Yeah, maybe.
Okay, so
I don't know what Tamer and Marco think. I have no idea.
No, I said that I see it very rarely.
Yeah, and I think because it takes time to happen, then we don't know if it is possibly secondary to the procedure or as part of the progression of atrophy in high myopic patients too.
Yeah.
Tough to say.
This is it. Yeah, yeah, I agree. I agree.
I have a question from Dr. Makreej. He's asking about the use of vertical scissors in comparison to the retinal trephine. Have you?
Well, there is only one. I mean, there is only one that developed the trephine in India, but we haven't. It's not available yet. We haven't used it much. But I think I like the vertical scissors because it's very well controlled. You know, there is no rush. Everything is very stable under PFO in the eye. You don't need bimanual techniques. You don't need a chandelier if it's only a macular hole, not a macular hole detachment. So for those cases, everything is stable under PFO and you can go step by step. I usually do a slightly heavier diathermy spots at one of them. So it creates a small micro hole. Then I can slip one of the tips of the vertical scissor through it and I start cutting. I can see the tip under the retina and I just go step by step. You don't have to go everything, you don't have to go all the way 360 in one step. You just cut, you adjust your hand, you can come out, you can go back again. And after you feel like you cut all the way 360, this is a step where you use a forceps. So I use a maxi grip forceps. You can slightly pull at the edge and you will see if all the edges around the graft are free. If one of the edges is still connected, you can see that, then you go back with the scissor and cut that snip. And then you pull. Once it seems completely free, then I usually switch to the finesse loop and move it. And like I said, I always try to make sure that all the edges, as much as I can of the graft, are clear from any laser or anything, because the more intact the edges, the more we have a chance of the linking of the neurosensory layers.
A question about the finesse loop. How much of it do you open?
Great question. So the ones that have used the finesse loop, they see that there is an actuation knob on the handle. The more you push it out, the more the finesse loop has a larger loop and is pushed out. The more you push it out, the more it becomes soft and you cannot control the tissue much. So for cases that are difficult to get the ILM or move things, I usually slightly get it out. If I just slightly push it out, it is more rigid. I can push more tissue. I can control more tissue. Once everything is good and I want not to create more friction, I don't want to push on the tissue, then I extend it more so it's more soft, so it doesn't create more pressure on the tissue as I move the transplant.
A question from Dr. Mohammed Hazzazi. Is there any chance that the PFCL bubble will be under the graft during the transplant?
Oh, great question. So only in patients that have macular hole without detachment, I have not seen any of that on the post-op. Even patients that have high myopic macular hole, when you take a picture with the Heidelberg OCT post-op day 1, you can see how the transplant is in place and the conformity of the transplant over that area of the hole and the PFO bubble in the sitting position. I have only seen PFO in cases that have retinal detachment with PVR. And those are the cases with the PFO that you can occasionally have some bubbles, but because of the location and how the transplant stays in place, when I have seen that bubble in the global study, I have seen it outside the transplant and not in the area of the transplant.
A question about whether you tried like localized detachment at the area with the BSS to cut the retinal flap from there, or I mean the transplant, or you always do it under flat retina where you go in with your vertical scissor?
Well, this is when I was responding to one of Carlos Matias' question about the location and so on and different ways of doing it. There are two ways, like I said. One of them, you can use the PFO and cut with the scissor. The second one is you can use a subretinal cannula and make a localized retinal detachment. You can cut it. For someone who's starting the technique, who hasn't used the vertical scissor, it might be easier to do it this way because then it's easier to go and cut. But in this situation, you may seriously consider doing by manual, so you wouldn't lose the flap and be able to move it to the fovea. But I think it is much easier for me that I do it with the vertical scissor once you get used to the scissor. And also I think that I don't like the idea of injecting in the subretinal space because mechanically you can be disrupting those cells that may have an implication on better function and survival of the transplant.
Thank you, Tamer. So you are implying that Steve is a beginner, eh?
Well, I didn't hear you. What did you say?
I said, I made a joke. You are implying that Steve is a beginner.
No. No, but I think it's exciting that, you know, a lot of surgeons have different ways of doing it. And, you know, there are different tips and tricks that we can pick up.
Yeah, sure.
Yeah.
I mean, I think if there is nobody else who wants to speak, Carlos or Faisal, we can conclude the session. It was great having you here all, guys. We abused all your time because it should have been 1 hour. It became 1.5. Probably because this topic becomes so much more interesting with time. I mean, we were used to ILM peelings, and now there are so many techniques and to be able to help our patients that made this session great. I see two raised hands. Carlos, you want to say something?
Hey, no, congratulations. It has been a great session. I enjoyed that a lot. You know, great done. Perfect. Thank you very much.
Congratulations, guys, to every one of you.
Thank you.
Thank you. Tamer, thank you very much again, and hope to see you soon in Real. And take care and stay safe.
Yeah. Thank you very much. It was great. Thank you.
Guys. Thank you.
Bye-bye.